Hello. Hello, good evening, everyone. Today we will continue our session-based discussion further, and today we will start with a very important topic that is fever. In last class, we have discussed about headache, and I hope you have liked that lecture. So today we will come and encounter the most common symptom that we all have faced in our life, and many patients by which are coming in our OPDs and IPDs and their ward, that is fever. Now, here in this class, our main motive is to first to know what is the pathogenesis and mechanism behind fever. Then we will deal what is fever with rash, and then we will come and see what is fever with unknown origin or pyrexia of unknown origin is. Because many times that we have seen that patient comes in our ward with fever, but we aren't able to diagnose. Ki diagnosis kya? So that is fever with unknown origin. So in this class, we will start with fever pathogenesis, fever with rash, fever with unknown origin. So starting with fever. So what is fever and how it is maintained? So first we have to note it down that our body generally maintain our core body temperature that is in the range between 36.5 degrees Celsius to 37.5 degrees Celsius. That is around 97.7 to 99.5 degree Fahrenheit. So our body maintains a core body temperature. And who maintains in body? That is our hypothalamus. So our hypothalamus maintains a core body temperature that is between 97.7 and 99.5 degrees Fahrenheit. And what we have, good evening, Zan. And what we have seen that anyone can tell me when we say fever, what is the definition of fever? How much should be temperature or of our body to say that it is a fever? Most easy question. Can anyone answer? That at what temperature we say we are having fever? Anyone? At what temperature we call that it is fever? Anyone? Mhm. So a temperature which is greater than 99 point degree Fahrenheit is known as fever. So we call fever when temperature is greater than 99.9 degree Fahrenheit. So now we will come to the this major organ, that is your hypothalamus, which maintains your core body temperature. So can anyone tell me which nucleus of hypothalamus helps to maintain fever or helps to maintain your core body temperature? There are many nuclei in hypothalamus, that there are perioptic nuclei, there are supraoptic nuclei, there are suprachiasmatic nuclei, there is anterior nuclei, there is posterior nuclei. So can anyone tell me which nucleus is important for maintaining our core body temperature? You have studied in this one in anatomy in first year. So there are two nucleus. First is your anterior hypothalamic nucleus, and other is your posterior hypothalamic nucleus. So these two nuclei help in maintain your core body temperature. So first is your anterior hypothalamic nucleus. So anterior hypothalamic nucleus is like AC. It works like AC. So when does AC start work? When there is when there is high temperature. So whenever your surrounding temperature increases, what will happen? AC will start to work. So your anterior hypothalamus nucleus will start to work. And whenever your surrounding body temperature will increase, what it will do? It will try to cool down your body. And how will you cool down your body? For cooling down of your body, you first have to decrease your heat production and increase your heat expenditure. So how your body will decrease your temperature? First, it will do sweating. So when sweat will be there, air will come, it will blow it out, and it will give a feeling of cool. First is your sweating. Other it will do cutaneous vasodilation. So when your peripheries, suppose this is your area of hand, when here blood vessels will dilate, so what it will do? It will do more heat will dissipate from the system. Your peripheral vessels will dilate and more heat will come out from the system. So cutaneous vasodilation and sweating. So anterior hypothalamic nucleus will do two functions. It will do sweating and it will do vasodilation whenever your body temperature outside go high. And other is your posterior hypothalamic nucleus. When it will start, it will start to do it when there is low temperature outside. Low temperature outside. So what it will do? Whenever outside temperatures is go down, especially you have seen in winters. What do you do in winters? In winter you start shiver. So shivering will start. What shivering do? Shivering increases your heat production. Shivering increases your heat production. So this is why these two nuclei, anterior hypothalamic nucleus and posterior hypothalamic nucleus. These two nucleus help us to maintain our core body temperature. Anterior hypothalamic nucleus works when outside body temperature is high. It works like AC. Okay. And posterior hypothalamic nucleus work when your outside body temperature is low. So it will do shivering. So now everyone knows that our core body temperature is maintained by which hypothalamic nucleus? Can anyone tell me in chat that which two hypothalamic nucleus help us to maintain our core body temperature? Anyone? This is your anterior hypothalamic nucleus and posterior hypothalamic nucleus. Now we see that there is a diurnal variation when it comes to temperature. So generally, your 6 a.m. temperature, and there is your 4 p.m. temperature. Your 4 p.m. temperature should be greater than 99.9, and your 6 a.m. temperature should be greater than 98.9 to call it as a fever. So there is a difference of 0.9 degree Fahrenheit between a morning temperature and evening temperature. So why is there is difference? Call a person to have fever at 4 p.m. its temperature should be above 99.9, and at 6 a.m. that is early morning the temperature should be at 98.9. So why this circadian rhythm is in fever? Because we all know that there is a hormone in our body known as cortisol. It has a diurnal variation. So you are seeing that at 6 a.m. your cortisol level is highest, and at evening, which is around 4 p.m., it is lowest. So when cortisol is high, it inhibits your fever center. It inhibits your fever center. That's why when cortisol is high at around 6 a.m., your body temperature or fever is at lowest. And at 4 p.m., when cortisol is low, your body temperature and fever is at your highest position. So the circadian rhythm which you see in your fever is due to diurnal variation of your cortisol hormone. Okay, everyone. So can now now you can anyone tell me that what is the reason behind your circadian rhythm of your temperature? Which hormone is responsible for your circadian rhythm of your temperature? Can anyone tell me in this comment section? Which hormone is responsible for your circadian rhythm of your temperature? That is your cortisol. So now we'll come to which are the best sites for looking of temperature. Starting with sites. So your best site is lower esophageal temperature. Okay. Best site is your lower esophageal temperature. This is your MCQ question. But generally, we can't measure this lower esophageal temperature because this is an invasive procedure. That's why we generally take your oral temperature. Other is your rectal temperature. Your rectal temperature. And your rectal temperature is always zero point 0.4 degree Celsius higher than oral reading. Other way of looking temperature is your there is something called as your tympanic membrane thermometers, which measures your radiant heat. Okay. Now, like your circadian rhythm, there is also a rhythm in menstruating females. Menstruating females. What we have seen that their morning temperature, that is AM, is generally lower during the 2 weeks before ovulation. It then rises by zero point 0.6 degrees Celsius with ovulation and stays at that level until menses occur. Fine. So, in menstruating female, their morning temperature is generally lower during the starting 2 weeks before ovulation, and it then rises by zero point 0.6 degrees Celsius with ovulation and stays at that level until menses occur. Now, we will move to an important topic, that is mechanism of fever. So, everyone knows that fever is greater than 99.9 degree Fahrenheit. Evening temperature is 99.9. Morning temperature should be 98.9. And the circadian rhythm of fever is due to your cortisol hormone. So there is a difference of 0.9 degree Fahrenheit between your early morning temperature and your evening temperature. Everyone is okay with that concept? Shall we move further? Now, now we will move on to what is the mechanism of fever. So, fever occurs in conjugation with an increase in the hypothalamic set point, that is from 37 degrees Celsius to 39 degrees Celsius. So what this is mean? We all know that our hypothalamus nuclei help to maintain your core body temperature. So whenever fever occur, so why fever occur? First, there is your something called as hypothalamic set point. So your normal hypothalamic set point is around 37 degrees Celsius. Okay. So whenever fever will be there, first your hypothalamic set point will increase. Your hypothalamic set point will increase due to some infection or due to some any kinds of inflammation. First, your hypothalamic set point will increase. Suppose it will increase from 37 to 39. So when your hypothalamic set point increases, your body will what your body will do? Your body will try to increase your body temperature to 39 so that it can match the temperature of hypothalamic set point. And by doing that, when your body is trying to increase its temperature from 37 to 39, so while doing this process, what is happening? It is known as fever. So first, whenever there is an infection, your hypothalamic set point temperature will increase. That's from 37, it will go to 39. When this hypothalamic set point will increase, your body will, what your body will do, your body will try to maintain your body temperature with your hypothalamic set point. So your body will increase your body temperature. So by the process by which your body will increase your body temperature and the symptoms you are getting in this process, it is known as fever. तो पहले मेरी बॉडी का टेम्परेचर 37 डिग्री सेल्सियस था नॉर्मल. अब कोई इन्फेक्शन हुआ, उस इन्फेक्शन की वजह से मेरा हाइपोथैलेमस का जो सेट पॉइंट है वो 37 से बढ़ के 39 हो गया. तो अब जब बॉडी को ये पता लगा कि यार टेम्परेचर 37 से 39 हो गया, तो बॉडी क्या करेगी? बॉडी अपना भी टेम्परेचर बढ़ा के 37 से 39 लेके जाएगी. तो जब बॉडी अपना टेम्परेचर 37 से बढ़ा के 39 लेके जाना चाहेगी, तो उस टाइम जो प्रोसेस होगी जिससे टेम्परेचर 2 डिग्री सेल्सियस मेरा बॉडी का बढ़ेगा, उस प्रोसेस के दौरान जो भी मैं एक्टिविटी करूंगा वो फीवर है. उस प्रोसेस के दौरान जो भी मेरी बॉडी एक्टिविटी करेगी वो क्या है? वो फीवर है. सो मैकेनिज्म. तो हाउ बॉडी will increase its core temperature to a new point after the increase of temperature of hypothalamic set point. सो अब हाइपोथैलेमस का जो सेट पॉइंट टेम्परेचर था, पहले हाइपोथैलेमस टेम्परेचर कितना था 37, अब 39 हो गया। अब जब हाइपोथैलेमस टेम्परेचर किसी इन्फेक्शन की वजह से 37 से 39 हो गया, एक इन्फेक्शन आया बॉडी में, कोई बैक्टीरिया का इन्फेक्शन आया, उस बैक्टीरिया की इन्फेक्शन ने हाइपोथैलेमस को ट्रिगर किया, जिससे हाइपोथैलेमस का सेट पॉइंट 37 से 39 हो गया। अब वो किस वजह से, तो हम बाद में देखेंगे। अब बॉडी क्या करेगी, बॉडी अपना टेम्परेचर बढ़ाने की कोशिश करेगी 37 से 39। तो अब क्या मैकेनिज्म बॉडी प्ले करेगी जिससे उसका टेम्परेचर 37 से 39 चला जाए? फर्स्ट, it will do cutaneous vasoconstriction. Okay, so body अपनी periphery में, सब body will try to vasoconstrict all its periphery. So जब when periphery will vasoconstrict, obviously your more blood will be in your vital organ, so body will conserve the heat. So heat conservation by cutaneous vasoconstriction. And अगर इससे भी काम नहीं चला, if cutaneous vasoconstriction से भी काम नहीं चला, what will body do? Body will do shivering. Shivering से क्या होगा? Shivering will produce heat. Either you have to conserve your heat or you have to produce more heat, because आपको अपनी बॉडी का टेम्परेचर बढ़ाना है। थर्ड, नॉन शिवरिंग थर्मोजेनेसिस, ये कहां पे होती है? ये होती है लीवर में। ओके, फोर्थ इज सम बिहेवियरल एडजस्टमेंट्स। अगर इन सब से भी बॉडी का टेम्परेचर नहीं बढ़ा, तो आप क्या करोगे टेम्परेचर बढ़ाने के लिए? व्हाट विल यू कैन डू टू इंक्रीज योर टेम्परेचर? यू विल पुट मोर क्लोथ्स। व्हाट यू विल डू? यू विल पुट मोर क्लोथ्स। तो सबको क्लियर है ये बात? व्हाट विल बॉडी डू? एवरीवन गिव मी थम्स अप इफ यू हैव क्लियर दिस कंसेप्ट, कि फर्स्ट, कोई इन्फेक्शन की वजह से बॉडी का हाइपोथैलेमिक सेट पॉइंट टेम्परेचर बढ़ेगा। उस सेट पॉइंट टेम्परेचर बढ़ने के बाद बॉडी अपनी बॉडी का टेम्परेचर उस हाइपोथैलेमस के सेट पॉइंट तक लेके जाएगी। उस दौरान बॉडी जो भी प्रोसेस करेगी, चाहे वो क्यूटेनियस वैसोकंस्ट्रिक्शन है, इधर इट इज शिवरिंग, इधर इट इज नॉन शिवरिंग थर्मोजेनेसिस, और इधर इट इज बिहेवियर एडजस्टमेंट, these all process which happen, they are collectively called as fever. So everyone is okay? Give me thumbs up if okay. Now this process, so they will continue this process till temperature of blood bathing the hypothalamic neurons matches the new set point or new thermostat setting. अब तो बॉडी प्रोसेस कब तक करेगी? सपोज दिस इज योर, no, suppose this is your hypothalamus and this is that nuclear hypothalamus. Okay, And suppose there is some neuron here, and there is your blood vessel. Okay, it is taking blood. So body will do this process till this neuron, which is near this blood vessel, when it this neuron get to know कि ब्लड वेसल में जो ब्लड है उसका टेम्परेचर भी बॉडी सेट पर तक बढ़ गया, तब वो बोलेगा ओके रुक जा. तब जब तक नहीं होता तब तक वो इट विल कंटिन्यू दिस प्रोसेस. सो दे विल कंटिन्यू दिस प्रोसेस टिल टेम्परेचर ऑफ ब्लड bathing the hypothalamic neurons matches the new set point. So the blood which is going near hypothalamus till its temperature is at the level of the same level of hypothalamic set point, these all four process will continue. Okay, everyone is understand? If it's okay, then give me a thumbs up. Then we will proceed further about hypothalamic set point. If everyone is clear about this, कि hypothalamic set point इन्फेक्शन जैसे hypothalamic set point का टेम्परेचर बढ़ेगा, बॉडी उसको कंपनसेट करने के लिए अपना खुद का टेम्परेचर बढ़ाने के लिए ये फोर प्रोसेस करेगी. ये प्रोसेस वो कब तक करेगी? जब तक जो ब्लड जो हाइपोथैलेमस के पास से गुजर रहा है, उस उसके हाइपोथैलेमस का जो न्यूरॉन है, जब वो ये देख लेगा कि हाँ भाई द ब्लड विच इज पासिंग नियर माय बाय मी हैज आल्सो द सेम टेम्परेचर, देन ही विल स्टॉप दिस फोर प्रोसेस. आफ्टर दिस what will happen when now you have given some antipyretic, means anti-fever medication, or infection decreases. So all these things, what they will lead to? They will decrease the hypothalamic set point. Okay, they will decrease the hypothalamic set point. अब क्या होगा? अब हाइपोथैलेमिक का सेट पॉइंट वापस से नॉर्मल पे आ जाएगा. तो फ्रॉम 39 टू 37 दिस अगेन. नाउ अब बॉडी को क्या करना है? अब बॉडी विल ट्राई टू कूल इट्स कोर टेम्परेचर. अब बॉडी को अपना टेम्परेचर डिक्रीज करना है. फॉर डिक्रीजिंग टेम्परेचर व्हाट विल बॉडी डू? इट विल डू क्यूटेनियस वैसो डायलेशन. और क्या कर सकते हैं? स्वेटिंग. क्योंकि we know if there is sweating, then air will go nearby past it, then you will feel cool. So either body will do vasodilation such that heat can be dissipated out from system, or it will do sweating. And other is your behavioral, that is your clothes removal. Reset downward of your hypothalamus set point. Now we will understand this by a graph. Suppose I have drawn this one graph. This is time and this is temperature. And this represent your hypothalamus. And this red represent your body temperature. Now, suppose this is your initial set point, 37, and this is your 39. So immediately, due to infection, your hypothalamic set point increases. Okay, what your body will do? Body will also try to increase its core body temperature. And in this process, there will be shivering. There will be chills. You know, initially fever comes with chills. This is so there will be shivering and there will be chills. After that, your body temperature will be okay. And as you have taken antipyretic, what will happen? your hypothalamic set point due to antibiotic or due to increase in infection, your hypothalamic set point will again come back to normal. Will again come back to normal. So now what your body will do? Your body will try to also decrease its body temperature. And in this process, what will happen? There will be cutaneous vasodilation. There will be flushing. So earlier, na, what doctor used to say that if they have given the antibiotic or if they have given the antibiotic or if fever has subsided, so you also see that when your fever subsided, when your fever decreases, your body will be warm, your ears will turn red, your flushing is there, cutaneous vasodilation is there. So it is also marker of subsiding of fever. So initially will be shivering and chills. That is like fever ठंड लग के आ रहा है. You know ना that doctor asked many times कि बुखार ठंड लग के आता है क्या? तो ये बुखार ठंड लग के इसलिए आता है. क्यों? क्योंकि पहले बॉडी को पहले आपका हाइपोथैलेमस सेट पॉइंट बढ़ गया, तो बॉडी को अपना खुद का टेम्परेचर बढ़ाना है, उस हाइपोथैलेमस सेट पॉइंट तक लेके जाना है. इन्फेक्शन की वजह से जो हाइपोथैलेमस सेट पॉइंट बढ़ा है, बॉडी कैसे लेके जाएगी? शिवरिंग से हीट प्रोड्यूस होती है, ऐसे लेके जाएगी क्यूटिनस वैसोकंस्ट्रिक्शन करके, चिल्स करके. जब हाइपोथैलेमिक सेट पॉइंट अचीव हो गया, अब बॉडी कुछ नहीं करेगी. अब ड्यू टू एनी रीजन, इफ hypothalamus temperature decrease either due to antibiotic medication or due to infection, now hypothalamus set point will decrease immediately. So now body will also decrease its temperature. How will it decrease in temperature? It will decrease either by vasodilation or through cutaneous vasodilation or through flushing. That's why in earlier times when temperature used to subside, we will see that patient is experiencing hot ears, red ears, flushing is there. So good evening, Ujjwal. So now everyone has understood this hypothalamus mechanism of body temperature set point. If no, then please tell me, because this is the most crux part of this lecture. So has everyone is everyone okay with this? Shall we proceed further? Or if anyone is having any doubt in this hypothalamus set point, then tell me that how hypothalamus set point work, how body temperature work with this. So I guess now everyone is okay with it. So if everyone is okay, then give me thumbs up. So we'll start with pathogenesis of fever. First, in pathogenesis of fever are your pyrogens. What are pyrogens? They are substance that cause fever. They can be exogenous. For example, any virus. It can be endotoxin when there is gram-negative bacteria. It can be enterotoxin when there is gram-positive bacteria like Staph aureus. And remember that endotoxin is the most important of pyrogens. A minimal dose of it will do its work. Okay. After that, so we have first seen the pyrogens. After pyrogens, there are pyrogenic cytokines. So what are these pyrogens? These are substances that cause fever. Either they can be from virus or either they can be from bacteria. From gram-negative, generally they are endotoxin, and from gram-positive, that is your Staph aureus, they are your enterotoxin. Now comes your pyrogenic cytokine. These are your interleukin 1, interleukin 6, TNF, then is your IFN alpha, then is your ciliary neutrophilic factor. And how this factor can be used? These factors can be induced by, first they are infective cause, then they are non-infective cause. Please, everyone who is seeing this lecture, please open your Harrison, because these are purely Harrison based discussion. So you can make notes of this, and then you can correlate with the Harrison, and then you can go and study your Harrison. You will find it very comfortable when after this lecture when you are reading your Harrison. Okay, so these factors can be used by the infective cause or non-infective cause. Infective cause, there are your bacterial, fungal, or virus. In non-infective is your pericarditis, your trauma, there is your stroke, then there is your vaccination. Now, what we have seen that these cytokine triggers the hypothalamus for new set point. So I have told you now earlier that some infection is there which increase your hypothalamic set point from 37 degrees Celsius to 39 degrees Celsius. So these are the cytokines which trigger the hypothalamus, and your hypothalamus then increases their set point. So how these substances trigger the hypothalamus to increase their set point? These pyrogenic cytokines interact with the endothelium of capillaries of circumventricular organ. Now, what is your circumventricular organ? So these these are the blood vessel capillaries which are around your third and fourth ventricle. And these circumventricular organs, their blood-brain barrier is incomplete. So any product can easily leak through this system near hypothalamus. So your pyrogenic cytokines will interact with uh, these capillaries, especially endothelium of these capillaries of circumventricular organ. By interacting with these, they will increase the prostaglandin E2. And this prostaglandin E2 will go to hypothalamus, and it will lead to increase the set point of hypothalamus from 37 to 39 degrees Celsius. And one more important thing, that there are four receptors of PGE2 is there, and important one is your EP3 for fever. So now we'll see the pathogenesis. So see, there is infection, then there are microbial toxins, mediators of inflammation, and there are some immune reactions. They will react with monocyte macrophages, the endothelial cell, and they will release your pyrogenic cytokines like interleukin 1, interleukin 6, and TNF alpha. Okay, this will go to hypothalamic endothelium, That is the endothelium of your capillaries of circumventricular organ. It will lead to increase in PGE2, prostaglandin E2. It will lead to increase in cyclic AMP, and it will elevate the thermoregulatory set point. That is, it will increase the temperature of your hypothalamus set point. Temperature will increase. Okay, and these microbial toxins can directly also damage your hypothalamic endothelium. So either through the cytokine process or through their diet, toxins can damage your endothelium of capillaries of circumventricular organs near hypothalamus. And through prostaglandin, their set point will increase. And I have told you also previously that whenever hypothalamus set point will increase, your body will try to increase its temperature. And when body increases temperature by either cutaneous vasoconstriction, either through chills, either through shivering, this process is known as fever. So this is the pathogenesis of fever. So everyone has understood it. Then give me thumbs up. Or if there is any doubt, then tell me. We will repeat it also if there is any doubt. So I guess everyone has understood this. So now we will move to other heading, that is your hyperpyrexia. So we all know that fever is temperature greater than 99 degree Fahrenheit. So there is another term that is hyperpyrexia. That is temperature greater than 106.7 degree Fahrenheit. Temperature greater than 106.7 degree Fahrenheit. Okay. So we will see what are the most common causes of hyperpyrexia. So CNS hemorrhages, any CNS trauma, CNS infection, they release interleukin 1, interleukin 6, and TNF alpha. And they are directly produced in CNS. They are directly produced in your CNS. And they bypass circumventricular organ. Because earlier, when these interleukins are produced in the periphery, they have to go to the circumventricular organ, they have to interact with their endothelium of their capillary, then they increase the set point. But here, in the problem is directly in CNS system. So the interleukin 6 and TNF alpha, they directly damage your hypothalamus system. So they are just bypassing the system of circumventricular organ. That's why they are able to produce more severe fever as compared to your normal mechanism of fever like your infection. So they produce high fever क्योंकि यहाँ पे प्रॉब्लम सीएनएस में ही है. यहाँ प्रॉब्लम सीएनएस में, इसलिए जो भी साइटोकॉन्स निकलते हैं उनको सर्कमवेंट्रिकुलर ऑर्गन से इंटरेक्ट करने की कोई जरूरत पड़ती ही नहीं है. ये डायरेक्टली जाके हाइपोथैलेमस को डैमेज करते हैं. एंड बिकॉज ये डायरेक्टली डैमेज करते हैं तो जो फीवर आता है वो काफी हाई आता है. दैट इज अराउंड 106.7 डिग्री फ़ारेनहाइट. दिस इज द सो most common reasons of hyperpyrexia are your CNS hemorrhages, CNS trauma, and CNS infection. Now, there is another term that is hyperpyrexia versus hyperthermia. That is your hyperpyrexia versus hyperthermia. So we will see what are the differences between hyperpyrexia and hyperthermia. So first, we all have studied about hyperpyrexia. It is temperature greater than 106.7 degree Fahrenheit. Okay. In this, there is increase in your hypothalamic set point. It is due to infection or any kind of hemorrhage. And as it is fever, so initial part there will be a cold because it is fever now. So body will, when from as hypothalamic set point is increased, so body will increase body temperature. To increase this body temperature, what will body do? Body will do cutaneous vasoconstriction, so that blood is diverted to your main vital organ. So periphery will turn as cold, and treatment is NSS. But what is happening in hyperthermia? Now, how hypothermia differs from hyperpyrexia is that in this temperature can be greater than 10 degree 4 Fahrenheit also. First, second, it is due to increase in your environmental temperature. It is because of increase in environmental temperature. So your environmental temperature is increased. Suppose there is very much heat outside, like right now in Delhi there was heat stroke. Many patients of heat stroke were coming because of outside heat. So due to increasing environmental temperature, your body temperature is increasing. So in this, your hypothalamic set point is normal. And as your outside environmental temperature is increasing, it is not a normal fever. So due to outside environmental temperature, your body skin will be hot and dry. So here body skin is your hot and dry. Compare it to hyperpyrexia, where it is cold. And what is the treatment in this condition? It is water therapy. And it does not respond to your antipyretics like your NSAIDs. So anyone is having any confusion between what is difference between hyperpyrexia and hyperthermia? Is everyone okay? गुड इवनिंग सर। हाँ हाँ, बिल्कुल पास हो जाओगे यार, अभी चालू करो तो पढ़ना। क्यों नहीं पास हो गया? इंपॉर्टेंट क्वेश्चंस करके जाएंगे तो जरूर पास होंगे यार डॉक्टर एम जी। टेंशन मत लो। ठीक है। इंपॉर्टेंट जितने भी आईएमपी जब हम करके जाएंगे, जो भी आ सके एनाटॉमी में आती है। नाउ वी विल सी हाउ टू अप्रोच अ पेशेंट ऑफ फीवर। फर्स्ट, a detailed history should be taken. Okay, and you will ask about chronology of event preceding fever. So till now, everyone has understood about fever, fever mechanism, pathogenesis. Everyone is okay with that? If anyone is having any problem, you can ask me right now. So, approach to patient. A detailed history should be always taken, and chronology of event. कि fever ठंड चढ़ के आ रहा है, fever कैसे आ रहा है, you should ask this kinds of all things in history. Now we will come to the physical examination part. So one more important thing is there, that same site should be used constantly to monitor the temperature. Suppose you are taking temperature from axilla. So in subsequent also, from 2 days, after 3 days, 4 days, you will again take temperature from your axilla area. Suppose if you are taking from oral, so in subsequent you will take from same side. So you always have to maintain the same side for looking temperature. You don't have to change the side of for looking at temperature again and again. Now there is a condition in which there are active infection. There are active infection, but in the absence of fever. So active infection in the absence of fever. What all are these conditions? These are in your newborns and elderly. Then are the patient of your chronic hepatic failure, chronic renal failure, and patient taking glucocorticoids and anti-cytokine therapy. So, because if you take anti-cytokine therapy, cytokines will not be there, and if cytokines will not be there, then fever will not be there. And if you are taking glucocorticoid, because glucocorticoid inhibits some steps in formation of your prostaglandin. Glucocorticoid inhibits some steps in formation of prostaglandin, that is your prostaglandin PGE2. So, if any step is inhibited, like if prostaglandin PGE2 is not there, then fever will not be there. Now, these are some diseases that present directly with fever as the cardinal sign. So in these disease, your fever is your cardinal sign. That is your infectious disease. That is your autoimmune and non-infectious inflammatory disorder. Then are your cancer. Then is your medication-related fever from the vaccine or due to drug fever. There are some endocrine disorder which present as fever. That is your hyperthyroidism. And last is your interesting hypothalamic malfunction. Due to any reason, if your hypothalamus is under malfunction, because suppose your anterior hypothalamus is not working, what will happen? Because anterior hypothalamus, what function is there? Anterior hypothalamus cools us when outside temperature is going up. And if suppose anterior hypothalamus is not working, then you will experience fever. Then comes your lab test. In lab test, you will do CBC, you will do your CRP, and you will do your ESR. Now you will ask me, sir, can we do interleukin 6 also? Because it is a marker in fever. Yeah, you can do interleukin 6. But there is problem in interleukin 6. The problem is that it vary during a febrile phase. So interleukin 6 generally vary with the febrile phase. But due to interleukin 6, CRP is increased. And your CRP that is increased due to interleukin 6, it does not vary with febrile phase. So CRP is better marker as compared to interleukin 6 in febrile phase. Now, now we will come other heading, that is fever in patient receiving your anti-cytokine therapy. Now, due to long use of your anti-cytokine medication. Now, if you are using your anti-cytokine medication for long time, then what will happen? Due to this long use of anti-cytokine medication, cytokines will not be released. So, first, your fever will not be there. That is okay. That is different thing. But your immune host response, which you are by which you are responding against bacteria, that will also decrease. So, chance of infection will also increase because of lowered host defense, there will be increase in infection. For example, we have seen that, for example, in Crohn's disease. In Crohn's disease, we use anti-TNF therapy. Okay. In Crohn's patient, we are using anti-TNF therapy. Now, due to increased use of anti-TNF therapy, in these patients, there are increased chances of your latent mycobacterium tuberculosis infection. Okay, in Crohn's disease, you are taking anti-TNF therapy for a long time. So the hidden infections in your body, like your mycobacterium tuberculosis infection, it will come. Also, patient taking this therapy, if they have a low grade fever, if they have a low grade fever, then in these patients, the low grade fever is also significant. It is significant. So, in patient taking anticytokine therapy, a low grade fever is also significant. Now, we will come to treatment of fever. So, generally, how do we treat fever? We treat fever by giving antipyretic medication, that is the NSAID. Now, one doctor was asking me that, sir, if we are having fever and we are taking antipyretic medication like PCM, so does it will decrease the chance of infection, or it will decrease my bacterial course, or it will, lead to shorten my period of infection. तो अगर भाई मेरा फीवर है और मैं एंटीबायोटिक ले रहा हूँ, मानो पैरासीटामोल ले रहा हूँ, और मुझे एक वायरल इन्फेक्शन हुआ, और वो इन्फेक्शन है 7 दिन का, उसका पीरियड होता है इन्फेक्शन का, क्या पैरासीटामोल मेरे लेने से क्या वो जो इन्फेक्शन का ड्यूरेशन है 7 दिन का, क्या वो छोटा हो जाएगा? सो इन स्टडीज वी हैव फाउंड दैट टेकिंग NSAIDs medication doesn't alter your course of infection. Taking NSAID doesn't alter your course of infection. So it is up to you. If you want to take, you can take it. Neither it increases the duration of infection, neither it decreases the duration of infection. It acts as a neutral. So, in most fevers which are associated with self-limited infections, such as common viral disease, the use of antibiotics is not contraindicated in these infections. But no significant clinical evidence indicates either that antibiotics delay the resolution of viral or bacterial infection, or that the fever facilitates recovery from infection or acts as an adjuvant to the immune system. In short, treatment of fever and its symptoms with routine antibiotic does no harm and does not slow the resolution of common viral and bacterial infections. So, they are not doing any harm or they are not doing also any good. So it is only up to you. If you feel that my symptom is very much, so if I want to take antibiotic, you can take it also. But either it doesn't increase the course or it is also not decreasing the course of infection. This thing you have to take in mind. Now, if we withhold the antipyretics, so if we withhold the antibiotics, what will do? It will help in diagnosis. It will help in diagnosis. It will help in diagnosis. And you will ask how? Because if you are not giving antibiotics, fever will be there. So by knowing the duration and course of fever. By knowing the duration and course of fever, you can get to know which kind of infection is this. So, suppose patient is having relative bradycardia. So, relative bradycardia is seen in your typhoid, your leptospirosis, your drug-induced fever. I will see. I will let you see causes of relative bradycardia. Starting with gram-negative bacteria. First is your Salmonella typhi. That is your typhoid. Then there is Coxsackie brenti. That is Q fever. Then there is your Leptospira. Then there is your Legionella and your Mycoplasma pneumonia. If it comes to tick-borne disease, then is your Rickettsia. Then there are others like Plasmodium in also malaria. In viral, there is yellow fever, and more important is your dengue virus. In viral myocarditis, because on general in myocarditis you get increase in heart rate, but in viral myocarditis you also can get bradycardia also. Then in non-infection is your drug fever, drug-induced fever, beta blocker use, malignant lymphoma, and CNS lesions. So after relative bradycardia, then is your Plasmodium vivax, in which fever comes every third day. Okay. Then is your Plasmodium malaria. Can anyone tell me that how Plasmodium malaria fever cycle is this there? In vivax, fever comes in third day. In Plasmodium malaria, fever comes every fourth day. Okay. Then is your Borrelia. In this, there is a relapsing fever. Then there is your Hodgkin lymphoma. In Hodgkin lymphoma is your Pell-Epstein type of fever, which is 3 to 10 days febrile, then a febrile episode, then then again a febrile episode is there. So first your Plasmodium vivax, which fever comes every third day. Then is your Plasmodium malaria, fever comes every fourth day. In Plasmodium falciparum, generally fever comes after 48 hours. Okay. In Plasmodium falciparum, fever comes after a 48 hours. In Plasmodium vivax, fever comes every third day. In Plasmodium malaria, fever comes every fourth day. And as Rajkumar is asking, that in Plasmodium falciparum and in Plasmodium vivax, and there is a Plasmodium ovale. In all of these, the fever comes after third day. Fever comes after third day. That is after 48 hours. Okay, Rajkumar. I hope you have got your answer. That in Plasmodium falciparum, in Vivax, ovale, in both of these conditions, fever comes after 48 hours. That is your third day. Now we will move to drugs. In drugs, we are having first is your NSAIDs, like your example, your PSM, PCM is there. Then comes your steroids, that is your glucocorticoids. Then comes anti-cytokine therapy, which is used in autoimmune and autoinflammatory disease. Can any one of you tell me the difference between autoimmune and autoinflammatory disease? Anyone who can tell me the difference between autoimmune and autoinflammatory disease? Anyone who can tell me the difference between autoimmune and autoinflammatory disease? In endocytokine therapy, we use interleukin 1, that is your enkyndra. Okay, so now we will see this graph. So fever is due to this prostaglandin PGE2. Okay, now from phospholipase, there is arachidonic acid, and this arachidonic acid through this cyclooxygenase enzyme is converted into endoperoxidase, which later on form prostaglandin. So this cyclooxygenase enzyme is initiated by NSAIDs. Okay, and thus conversion of phospholipase to arachidonic acid is inhibited by corticosteroid. This how these steroids and this NSAIDs work in stopping of fever. This is their mechanism of action. And what we have also seen that whenever there is fever, with increase of 1 degree Celsius in fever, oxygen demand increases by 13%. So, by 1 degree Celsius increase in fever, your oxygen demand increases by 13%. So, patient of, of CVS, patient of respiratory illness, and patient of your CNS diseases. So, patient of your cardiovascular system, patient of your respiratory illness, and patient of your CNS disease should be managed carefully. Because in these patients, 1 degree Celsius increase in fever increase oxygen demand by 13%. And this patient already are suffering. So if any fever is there, it will also enhance their illness. So these patients we should manage promptly. Now, now after finishing fever, we will come to other important topic, that is fever with rash. So we will start with fever with rash. Now, before starting the topic with fever with rash, we should know what is rash. So there are two types of lesion in the body. One is your primary skin lesion and other is your secondary skin lesion. So primary skin lesion are those which developed as a direct result of disease process. And secondary lesion are those which evolve from primary lesion. It means primary lesion is the first damage to your skin and it will appear. And secondary lesion appears on your primary lesion. So there is primary skin lesion and there is your secondary skin lesion. And secondary skin lesion appear over primary skin lesion. Now we will move to types of primary skin lesion. First is your macule and patch. Now, what is macule? Macule is change in skin color which is nor raised nor depressed. So, what is macule? In macule, there is only a change in skin color. You can't feel this. Suppose this is my skin and this area color is changed, but I can't feel this. I can only see this. Now, so in macule, there is only change in skin color. Neither there is any height, neither there is any depressed area. On this. And macule is generally less than 0.5 centimeter, and patch is greater than 0.5 centimeter. So you can see there is change in color, but neither they are increased or neither they are decreased. Now, macule is of many types. First, there is a hyperpigmented macule in which there is increase of pigmentation. Like you can see in this disease, in this patient, there is hyperpigmentation is there. So there is increase in pigmentation. Other is your hypopigmented macule in which there is decrease in pigmentation. Like you can see in this disease, that there is hyperpigmented macule is there. So everyone is okay. What is macule? What is patch? Is there any confusion between macule and patch? Then you can tell me right now. Here we are studying fever with rash. So before studying fever with rash, we should know what are the different types of primary skin lesion. We have covered macule and patch. Macule is less than 0.5 centimeter. Patch is greater than 0.5 centimeter. Macula is change in skin color, which is neither raised or not depressed. Because many times you find a patient with different kinds of rashes, but you are not able to say that which kind of rash is this, and you simply label it as a rash. But now you should be able to tell which kind of rash is this. Either it is macule, it is patch, it is papule, either it is plaque, it is nodule, it is vesicle, it is bulla. So you should able to tell after this lecture. This is your hyperpigmented macule in which there is increase in pigmentation. Then comes your hyperpigmented macule. And see this boy, macule, which is less than 0.5 centimeter, and patch, which is greater than 0.5 centimeter. This is your patch, and this is your macule. There are also some erythematous red macule also. So macule can be hypopigmented, it can be a hyperpigmented. It also can be erythematous red macule also. If less than 0.5 centimeter is macule, if greater than 5 centimeter is papule. So papule mac, and it is erythematous red macule. Now we will come to other topic, that is your papule, plaque, and nodule. So what are papule, plaque, and nodule? These are your circumscribed solid elevated lesions. If these are circumscribed solid elevated lesions, papule one, oh, macule and patch was not elevated. They are elevated. If it is less than 0.5 centimeter, it is papule. If it is greater than 0.5 centimeter, it is plaque. In plaque, na, skin texture is also changed. In plaque, skin texture is also changed. And if greater than 0.5 centimeter and depth is greater than height, or it is firm, it is firm, elevated, and circumscribed, then this is called your nodule. So this is your papule. This is less than 0.5 centimeter. This is your plaque. It is greater than 0.5 centimeter. This is your nodule. Here you can see there is depth also. So in nodule, there is depth also. Okay, if anyone is having any doubt, you can just message me. Have you understood what is the difference between papule, plaque, and nodule? Now see, these are your papule. These are less than 0.5 centimeter. Then comes your plaque, which is greater than 0.5 centimeter. And you can see there are skin changes also. So in plaque, there are skin changes also. And see, this is your nodule. So whenever you feel a nodule, na, you feel that there is depth also. In papule plaque, there is no depth, but in nodule, there is depth also. See, this nodule, it is elevated, it is firm and circumscribed, and it has depth also. It has depth also. That's why it is nodule. After this, we will come to fluid filled lesion. So they are divided into, if greater than 0.5 centimeter, then it is vesicle. Then it is vesicle. If less than 0.5 centimeter. If greater than 0.5 centimeter, then it is bulla. So see this figure. These are less than 0.5 centimeter. So these are your vesicle. This is your greater than 0.5 centimeter. So this is your bulla. Is everyone is okay with this concept of vesicle bulla? Vesicle is less than 0.5 centimeter. Bulla is greater than 0.5 centimeter. Then comes your first field lesion. Either it can be a pustule or either it can be your abscess. What is different between pustule and abscess? Abscess is large. See, this is your pustule. This is small. And this is, see this. This is your abscess. Okay. Then comes your extravasation of RBC. When your RBC leaks out of vessel, that is your extravasation of RBC. It is divided into three parts. First is your petechiae, then is your purpura, then is your ecchymosis. What is petechiae? It is less than 2 mm. What is purpura? It is between 2 mm to 1 centimeter. And what is ecchymosis? It is more than 1 centimeter. It is more than 1 centimeter. Now, there's a term we always used to hear, na, that is a either is purpura is non-palpable or it is palpable. So, purpura, if it is due to extravasation of RBC or is due to vasculitis, because in vasculitis also purpura is there. If it is due to extravasation of RBC, it is non-palpable. And if it is due to vasculitis, it is palpable. Because in vasculitis, there is inflammation of vessel. So if there is inflammation of vessel, you can feel it, you can palpate it. So in vasculitis, your purpura will always be palpable. But in normal, for suppose there is any clotting disorder, clotting disorder. If there is any bleeding disorder, in here, purpura will be non-palpable. Now, you will ask me, sir, in macules, you have teach us that there is a macule that is this red macule, which is due to erythematous red macule. Okay. And if suppose we have to distinguish between, suppose we have to distinguish between purpura versus this erythematous red macule. Then how we will distinguish? Now, this erythematous red macule is due to, hello, Mashroor Ahmad, how are you? Have you understood fever mechanism, fever pathogenesis? And now here we are discussing about primary skin lesions. In this day, we are discussing about vesicle, bulla. Now we are discussing about extravasation for RBC. Yeah. Mushu, also, I will share my Instagram handle also. So, purpura versus erythematous red papule. Now, erythematous red papule, in this, there is redness. There is redness. And why there is redness? This redness is due to vasodilation. But here, redness is due to extravasation of RBC, is due to extravasation of RBC. So, now, here is a phenomena which these are your non-blanching, but these erythematous are blanching. So, what do you mean of blanching? If by a glass light, if by a glass eye, you will press this erythematous red papule, the redness will go. Why redness will go? Because this redness was due to vasodilation. But when this slide, you will press this purpura, this will not blanch. It will remain red. So this how you can distinguish between purpura versus the erythematous red macule. So by blanching, it will not go away. So everyone is okay with this concept. How can you distinguish between purpura versus erythematous red papule? And why in purpura there are two types of purpura. One is palpable purpura and other is non-palpable purpura. Non-palpable purpura is due to clotting or bleeding disorder, and palpable purpura is due to vasculitis. Anyone is having difficulty? Give me thumbs up if everyone has understood this. Then we will proceed further. Is everyone okay with this concept? Is everyone understood that primary skin lesions or purpura, vesicle, bulla? Now we move to cyst. Now, how to differentiate between cyst and abscess? Now, cyst is enclosed cavity with lining filled with fluid. So, this is important. Cyst is an enclosed cavity with lining. You can clearly demarcate its cyst. Na? There is a particular lining in cyst. But in abscess, there is not a clear-cut marker or clear-cut lining is there. Then comes last is your wheel. Now, in wheel, you have to know 3 points. That it is erythematous, it is edematous, and there is evanescent. What do you know erythematous? It is red. due to vasodilation. What do you mean by edematous? It is there is swelling there. And what do you mean by evincement? That it disappears by 24 hours. So these are your wheals. Na? In which patient wheals are there? In urticaria patient. So patient will come to you and he will say, sir, which and these wheals in these wheels there itching is there. Itching is there. So patient will come to you and say कि सर कल रात खुजली बहुत हो रही थी और कुछ उठा उठा सा लाल लाल सा लग रहा था और अब वो चला गया. So there is redness, there is swelling, and they disappear by 24 hours. These are the characteristics of wheal, which is seen in urticaria patient. So everyone is okay. Now we will come to the causes of fever with rash. Starting with infectious causes. First, we will start with viral xanthema. These are more common in children and includes measles, rubella, and rosella. Now, in bacterial infections such as scarlet fever, which are caused by streptococcus pyogenes and toxic shock syndrome. You can see fever with rash in rectal infection like in Rocky Mountain spotted fever, in meningiostoma, which is caused by Neisseria meningitis, which present with petechia or purpuric rash and fever. Then comes your allergic reaction. That are your drug reaction, which can cause fever and variety of rashes can be there in your drug-based allergic reaction. That is your Stevens-Jones syndrome, and that is your urticaria. I have explained you about urticaria also. No? Then comes your autoimmune disease, like your SLE, in which there is fever with facial rash that is butterfly shaped. Then comes your Kawasaki disease, which is predominantly seen in children, which include fever, rash, conjunctivitis, and mucosal changes. Then, hello, Dr. Vipul, how are you? Then comes your vasculitis, such as HSP, Hypothalamus popula, which causes fever also. So these all are a condition which present with fever with rash. Now, we generally see a most common kind of rash that is your maculopapular rash. This is the most common rash we see. Now, what do you mean by maculopapular rash? First, there is macule as well as there is papule in this. First, there are macule as well as papule. Okay, and these rash are red. So we have seen that there are erythematous red macule rash. So these are maculopapular erythematous red rashes are there. So a maculopapular rash which is made up of both flat and raised skin lesion. That is a macule and papule. A macular rash is a marker of many diseases that is an allergic reaction. Most of the time, it is caused by a viral infection. Here you can see the macule, and here is your papule. It is somehow raised. So, if the patient present you with maculopapular rash with fever, what you will see? You will see any recent sick contact history there is not. If no, then you will encounter the any travel history. If travel history is there, then either it can be a Rocky Mountain spotted fever or it can be a Zika virus or a West Nile virus. If there is no endemic travel history, then you will encounter about any drug history. If there is any recent sick contact history, then you will see whether this rash is centrally distributed or this rash is peripherally distributed. If this rash is a peripherally distributed rash, then it is more common in hand, foot, mouth disease or meningococcemia. Or if this is a centrally distributed rash, then it can be a rubella or a parovirus B90. So I again repeat. First, you will see either this rash is a maculopapular rash, is with fever or not. If it is fever with rash, then you will see if there is any contact history or not. If yes, you will see is your rash centrally distributed or peripherally distributed. If no, you will see any travel history to any endemic area. If there is any travel history to endemic area, either it can be a Rocky Mountain spotted fever or it can be a Zika virus. If there is no history to travel to endemic area, then you will encounter about the history of drug. Okay, so now we have come to end of our class, and we have come to a very much important topic, that is fever of unknown origin. That is your pyrexia of unknown origin. So many times now, patient comes to us and patient is admitted in our ward in our OPD, and we are like, sir, patient admitted है, एक दो तीन चार दिन हो गए, सब इन्वेस्टिगेशन करवा लिया, बट कोई डायग्नोसिस नहीं बन रहा. सो पेशेंट का डायग्नोसिस पेशेंट का डायग्नोसिस नहीं बन रहा. सो then your residents will ask to you, sir, can we label it as a fever of unknown origin or pyrexia of unknown origin? So there are some criteria. This criteria should be fulfilled when you should label the patient as a fever of unknown origin or fever of pyrexia of unknown origin. We will see that criteria. Starting with definition. So definition is that a temperature greater than 38.3 degrees Celsius, that is 10 Fahrenheit, on several occasions. So temperature which is greater than 10 degree Fahrenheit on several occasions. More than 3 weeks of illness should be there. And failure to reach a diagnosis despite 1 week of inpatient investigation. तो पेशेंट को 101 डिग्री से ज्यादा बुखार है, ये बुखार उसको 3 हफ्तों से है, और 1 हफ्ता हमने पेशेंट को अस्पताल हॉस्पिटल में भर्ती किया और पूरी जांचें करी 1 हफ्ते तक, उसके बाद भी कोई डायग्नोसिस नहीं बना, तब हम उसको लेबल करते हैं पायरेक्सिया ऑफ अननोन ओरिजिन. बट ये डेफिनेशन है, दिस इज ओल्ड डेफिनेशन, दिस इज ओल्ड definition. Now there is a new definition of Pyrogen of unknown origin. We will see that definition. So it starts with first, fever should be greater than 101 degree Fahrenheit on at least 2 occasions. So fever which is greater than 10 degree Fahrenheit on at least 2 occasions. Second, illness duration should be greater than 3 weeks. Third, no known immuno immunocompromised state. Okay. 1, 2, 3. This is a new definition. Fever greater than 101 on at least 2 occasions. Illness duration greater than 3 weeks. No known immunocompromised state. Then comes your last, that is diagnosis that remain uncertain after thorough history taking, physical examination, physical examination, and obligatory investigation. So, what are these obligatory investigations? These are your ESR, CRP, platelet count, leukocyte count, hemoglobin, your electrolyte, your creatinine, your total protein, your alkaline phosphatase, your ALT, AST, LDH, creatine kinase. Why creatine kinase? Because sometimes inflammatory myopathies can also present as fever. Your ferritin, because ferritin is a marker of long-standing inflammation. Your antinuclear antibodies, because sometimes SLE can present as fever. Rheumatoid factor also. Protein electrophoresis for multiple myeloma, because in 1% population of multiple myeloma, 1% patient multiple myeloma can present as fever. Your urine analysis, your blood culture, and blood culture should be at least free blood culture. Okay, then comes to urine culture, then chest X-ray, abdominal ultrasound, then tubercular skin test, and then comes last your interferon gamma release assay, that is IGRA. So now everyone has understood this new definition of pyrogen of unknown origin. So then give me a thumbs up if you have understood the new definition of pyrogen of unknown origin. That is your fever which is greater than 10 degrees Fahrenheit on at least 2 occasions. Illness duration is greater than 3 weeks. No known immunocompromised state. And diagnosis that remain uncertain after thorough history, physical and obligatory investigation. And these obligatory investigations I have told you that are CRP, ESR, HB, electrolytes, that is AST, ALT, chest X-ray, electrophoresis, protein electrophoresis. Your blood culture and blood culture should be at least three blood culture. Your urine culture, your chest X-ray, your tubular skin test, and your interferon gamma release assay, that is your IGRA. Now, there is a another term also that is known as inflammation of inflammation of unknown origin. What is it? In this, there is elevated CRP or ESR for at least 3 weeks. Okay, in a immunocompetent patient with a normal body temperature, despite of proper history and examination. So now you understand. So what is difference between inflammation of unknown origin and pyrexia of unknown origin? In pyrexia of unknown origin, there is fever. In inflammation of unknown origin, fever is not there, but unless until there is elevated CRP and ESR, and that is also for at least 3 weeks. Now we will come to etiology and epidemiology. So first we know what that is what is most common cause in non-Western countries for pyrexia of unknown origin, like countries like India. So what's the most common cause in country like India for pyrexia of unknown origin? It is infection. And infection also, what is most common? It is TB. Is TB. When it comes to most common in Western countries, it is non-infectious inflammatory diseases. That is your NIID, in which there are your autoimmune. So, and can anyone tell me what is the difference between autoimmune disease and autoinflammatory disease? And if not, then tell me if you don't know this difference. Anyone who can tell me what is the difference between autoimmune diseases and autoinflammatory diseases? It is autoinflammatory. Then comes your granulomatous disease, and last is your vasculitis. So, what autoinflammatory? In autoinflammatory comes your N. It is due to your innate immunity, and autoimmune disease is due to your adaptive immunity. I repeat, in autoinflammatory comes your N. That's why it is due to innate immunity, and autoimmune is due to then adaptive immunity. In your autoinflammatory, what condition are there in autoinflammatory? Familial Mediterranean fever. and in autoimmune are your Arya and Jogren. So now, can anyone tell me what is the difference between autoimmune and autoinflammatory disease in comment section? What is the difference between autoinflammatory and autoimmune disorders? Can anyone now tell me in comment section? In autoinflammatory, there is N. That's why it is due to innate immunity. It is due to innate immunity. Now we will come to causes of pyrexia of unknown origin. So what is the most common cause of pyrexia of unknown origin? It is infection. Then is your neoplasms or malignancy. Then comes your NIID, that is non-infectious inflammatory diseases. Then comes your miscellaneous causes. Okay. Now there is one interesting data which they have done in Western countries. Now what is the data? In Western countries, what they have found that in a cohort study that one-third patient, one-third of patients were still undiagnosed. So in one-third of patients in Western countries, still they are not able to make the diagnosis of after they have labeled them Pyrogen of unknown region and they have done a full investigation. Still diagnosis is not there. But interesting part is that when we compare it to earlier time, that is 60 years ago, the data of this one-third patient has increased. Now you will ask me, sir, why this one-third patient which are undiagnosed have now increased compared to 60 years back? Because in 60 years back, there was not that much of investigation. Now, in less than 3 weeks, we do all the investigation. So people who come under Pyrogen unknown origin are those are very much difficult to diagnose. Earlier, earlier there were no that much of diagnosis. So so people who come in one-third were less. But now people who come in, people who fit in the criteria of Pyrogen unknown origin, after a thorough investigation of 3 weeks, then there is difficult to get them diagnosed. But earlier, as there were not that much of investigation, so there were patients which were undiagnosed were less. But now, as in less than 3 weeks, we have many diagnoses like CT, X-ray. So diagnosis is made earlier. So any patient now with standard Pyrogen unknown origin after doing this thorough investigation is difficult to diagnose. That's why this cohort is increasing as compared to previous 60 years data. Now we will see what all are the causes of this Pyrogen of unknown origin. Now starting with this, that is your bacteria. First comes your abdominal abscesses. Then comes your apical granuloma. Then comes your appendicitis. Then comes your cholangitis. Then comes your cholecystitis. Then is your diverticulitis. Okay. When it comes to fungal, it is your aspergillosis. Then there are your blastomycosis. There is your candidiasis. Then comes your coccaidomycosis. Then your cryptococcus. When it comes to parasitic, then it is your amoebiasis, babesis, fasciculosis, and malaria. When it comes to viral, these are your tick fever, your cytomegalovirus influenza, CMV, that is your dengue. Then comes Epstein-Barr virus infection. Then comes West Nile virus infection. In non-infectious, there are your autoimmune diseases, there are your vasculitis causes, then there are your granulomatous diseases, then comes your autoinflammatory syndromes. In neoplasm, there are your hematological malignancies like amyloidosis, Castleman disease, your Hodgkin disease, and most importantly, your multiple myeloma. Then there your myelodysplastic syndrome. Then comes your myelofibrosis. Now, what we have seen that that atypical presentation of common diseases is more common to cause Pyrogens of unknown origin than your rare disease. So, because when we are suspecting Pyrogens of unknown origin, we are suspecting it is Pyrogens of unknown origin. What we think that it may be a rare disease, but rather than being a rare disease, these are your atypical presentation of your common disease. For example, your tuberculosis. Generally, your tuberculosis affects your lung, and it is your pulmonary tuberculosis. And pulmonary tuberculosis patient present as a cough with sputum, hemoptysis there. So you can easily find out this. But if there is any atypical presentation of TB, like suppose there is consolidation of lung due to TB, or if there is any extra pulmonary TB, like TB in liver or in any other organ, so it is more difficult to diagnose. So pyrexia of unknown origin is more due to a atypical presentation of common disease rather than a rare disease. So this is the most important thing that you have to take into consideration. For example, a patient of Crohn's disease, it will present like a fever. It is an atypical presentation of a rare disease. For example, patient of a multiple myeloma. Now, in multiple myeloma, only one patient present is fever. So, if patient of multiple myeloma is presenting to you as a fever, then it is an atypical presentation of a common disease. So, you have to take in this consideration. So everyone is clear with this concept that Pyrogens of unknown origin is due to atypical presentation of a common disease rather than being a rare disease. If everyone is okay, then give me a thumbs up. If you understood this concept, then in Pyrogens of unknown origin, we have to find out the common disease rather than going into rare disease because it can be due to a atypical presentation of common disease like TB. Is everyone is okay with it? Then give me a thumbs up. We will go further. Now we'll come to most common cancerous cause of fever of unknown origin. That is your malignant lymphoma. That is your malignant lymphoma. Now, there is a other term that is a drug induced fever. Now, what are the common drugs which do drug induced fever? That is your allopurinol, that is your carbamazepine, that is your phenytoin, that is your furosemide, that is your antimicrobials. So, I remember a case, there was a boy who was labeled as an Pyrex of unknown origin, and he has come to us in OPD. And he was, for some reason, he was taking antimicrobial, and he was taking cefixime tablet. He was taking tablet cefixime. So I told him to stop this cefixime tablet. So, and patient was having fever 2 or 3 weeks. So when he stopped his cefixime tablet, what we seen that after 3 days, fever was subside. So this fever was due to cefixime. So whenever you're taking the history of pyrogens of unknown origin, it is important that you should take a history of drug, that you must take a history of drug, because drug induced fever is very much common in this patient. So if there is any kind of drug, check is this drug is doing fever or not. If you think that this drug might can do fever, you stop that drug, because drug induced fever generally respond within 72 hours, and if it's not responding within 72 hours, then it is not drug induced fever. It if if we stop drug, it responds within 72 hours. And remember, generally all drugs cause fever except your digoxin. Except digoxin, all drugs cause fever. This is the common consideration. And drug-induced fever many times present as a relative. I have, because we have seen that table of relative bradycardia in there, in last section was there mention of drug-induced fever. Relative brady plus hypotension can be there. See this table. This table of causes of relative bradycardia fever. In this, you can find that non-infectious causes, in non-infectious cause is your drug fever. Now comes your other term, that is your factitious, factitious fever. Now, what is this term known as factitious fever? It is artificially induced it is an artificially induced fever. And how can we artificially induce fever? Suppose injecting by IV injection of any unsterile water. Suppose you have injected any unsterile water in your body by doing IV injection. So you will get an artificial induced fever. That is your factitious fever. Another term is there that is known as fraudulent fever. So what do you mean by fraudulent fever? In this fever, patient manipulates with thermometer. Suppose you have seen one movie of आमिर खान, उसमें एक लड़का होता है, उसको जैसे ही बोलते हैं बुखार है क्या, जैसे ही आमिर खान के कहीं जाता है वो थर्मामीटर लेता है और थर्मामीटर को दूध वाले गिलास में डाल देता है, एंड सडनली it comes out of fever 106. And have seen this also. There was a patient female who was admitted in our ward now for some any kind of illness, some respiratory illness was there. So he was having a boy, and that boy was around 12, 13 years old. And what he was saying to us again and again, he said, fever aa raha hai, मेरे को fever aa raha है, मेरे को बुखार आ रहा है. And what we observed that he was having a kettle behind it. Now there's a kettle. So he generally dips in this kettle. There was a hot water in that kettle. So he generally dips his thermometer in that kettle, hot water, and he was like, "Sir, देखो मुझे 104 बुखार आ रहा है." So this is your fraudulent fever, in which patient manipulates with thermometer. Now, after seeing this, we will see how should we approach a patient of Pyrogens unknown. That is more important. First, we will come to diagnosis. फीवर 38,101 से ज्यादा है? हाँ ज्यादा है। इलनेस 3 वीक से ज्यादा है। कोई इम्यूनो कॉम्प्रोमाइज स्टेट है? नहीं है। इट मीन्स इट इज पायरेक्सिया ऑफ अननोन ओरिजिन। उसके बाद विल डू हिस्ट्री एंड फिजिकल एग्जामिनेशन। ओके, कर लिया भाई हमने हिस्ट्री फिजिकल एग्जामिनेशन। हम एंटीबायोटिक और ग्लूकोकॉर्टिकॉइड स्टॉप कर देंगे। क्यों स्टॉप कर देंगे? क्योंकि अगर एंटीबायोटिक जो है, अगर बिकॉज यू हैव सीन ना कि पेशेंट एडमिट होता है तो डॉक्टर बोलता है कि इसका ब्लड कल्चर यूरिन कल्चर पहले भेज दो एंटीबायोटिक स्टार्ट होने से पहले, बिकॉज एंटीबायोटिक विल हैम्पर द बैक्टीरिया। तो अगर एंटीबायोटिक देने के बाद वी डू ब्लड कल्चर यूरिन कल्चर, वी विल नॉट एबल टू ग्रो दैट ऑर्गेनिज्म। सो दैट्स व्हाई ऑलवेज स्टॉप एंटीबायोटिक ट्रीटमेंट। व्हाई ग्लूकोकॉर्टिकॉइड? बिकॉज ग्लूकोकॉर्टिकॉइड से लिम्फेडेनोपैथी डिक्रीज होती है। ग्लूकोकॉर्टिकॉइड से लिम्फेडेनोपैथी डिक्रीज होती है, इसलिए स्टॉप एंटीबायोटिक एंड ग्लूकोकॉर्टिकॉइड। उसके बाद जितनी भी हमारी ऑब्लिगेटरी इन्वेस्टिगेशन है वो सब करवा लो। सारी ऑब्लिगेटरी इन्वेस्टिगेशन करवा ली हमने, एक्सरे, यूएसजी, प्रोटीन इलेक्ट्रोफोरेसिस, ल्यूकोसाइट काउंट, सब हमने करा लिया। उसके बाद एक्सक्लूड मैनिपुलेशन विद थर्मामीटर, मतलब फ्रॉडुलेंट फीवर, फैक्टियस फीवर भी उसके बाद हमको रूल आउट करना है। एक बार हमने वो रूल आउट कर लिया, उसके बाद हमको देखना है कि यार कोई ड्रग इंड्यूस फीवर तो नहीं है। तो हमें जितनी भी ड्रग्स है वो सारी स्टॉप करनी है। अगर ड्रग स्टॉप करने के बाद फीवर नहीं जाता, देन वी विल मूव टू पीडीसी। सो नाउ व्हाट आर दिस पीडीसी? तो अब हमें उसकी ड्रग स्टॉप करनी है। ड्रग स्टॉप करने के बाद हमें कहा आना है? यस राम। नो नो, नॉट इम्यूनोसप्रेसिव ड्रग। वी हैव टू स्टॉप एंटीबायोटिक्स एंड ग्लूकोकॉर्टिकॉइड्स। एंड हाँ, इम्यूनोसप्रेसिव जैसे कुछ साइटोकाइन वगैरह वो भी हमें बंद कर देने, क्योंकि उनसे भी अगर हमको इम्यूनोसप्रेसिव ड्रग देते हैं, जैसे मान लो एंटी साइटोकाइन हमने दे दिया, तो उससे भी पेशेंट को फीवर नहीं आएगा। तो वो मैनिपुलेट कर सकता है हमारी रीडिंग। क्योंकि अगर हम एंटी साइटोकाइन थेरेपी दे रहे हैं और पेशेंट को मानो इन्फेक्शन है, इन्फेक्शन तो उसको होता रहेगा बट फीवर हम उसको आएगा नहीं। तो फिर अब हमको क्या लगेगा कि यार फीवर तो आ नहीं रहा, इसमें इन्फेक्शन भी नहीं है, बट अंडर उसको इन्फेक्शन चल रहा है। तो हमें इम्यूनोसप्रेसिव ड्रग भी स्टॉप करनी है। ओके, so exclude manipulation with thermometer. Then we will come to PDC. Now, what are these PDC? These are your localizing signs or symptoms or potentially pointing towards any diagnosis. These are your diagnostic clues. PDCs are your diagnostic clues. So, आप क्या देखोगे यार, पेशेंट को साइन को सिम्टम तो नहीं जिसको आप मिस कर रहे हो। आप वो साइन सिम्टम पकड़ोगे, वो पीडीसी पकड़ोगे, और अब मान लो कोई पेशेंट है, अब उस पेशेंट को बार बार खांसी हो रही है, बट आपने उसमें कोई वो इन्वेस्टिगेशन करी, तो आप उस खांसी सिम्टम को पकड़ोगे, ये आपकी पीडीसी होगी। और उस पीडीसी के को आप जा जाके उसको डायग्नोज करोगे। अगर उस पीडीसी को डायग्नोज करोगे, आपका डायग्नोस बन जाता है, देन इज वेरी गुड। बट काफी बार पीडीसी को डायग्नोज करने के बाद भी आपका डायग्नोसिस नहीं बन सकता। एंड समटाइम पीडीसीज कैन बी एब्सेंट और मिसलीडिंग। भाई कोई लोकलाइजिंग साइन है बट वो एब्सेंट भी हो सकता है और मिसलीडिंग भी हो सकता है। मान लो एक पेशेंट है, उसको अब खांसी हो रही है, एंड नाउ यू इवेल्युएटिंग हिम हर फॉर कफ, बट लेटर ऑन यू रियलाइज दैट कि भाई इस पेशेंट को तो पैंक्रियाटिक मैलिग्नेंसी या पैंक्रियाटिक कैंसर निकल गया। सो इन दिस पेशेंट यू आर थिंकिंग दैट पीडीसी वाज कफ एंड यू वर थिंकिंग ऑन दैट टर्म, बट अब पेशेंट को क्या निकल गया? पैंक्रियाटिक कैंसर निकल गया। तो यहाँ पे जो आपका पीडीसी था वो क्या था? मिसलीडिंग था। So sometimes PDC can be misleading. But if you're finding any PDC, you must go with that PDC and you diagnose that and you get more investigate about that PDC. Okay. So PDC can be absent or misleading. After that, you can do gyroglobin ever and fundoscopy. Fundoscopy क्यों? भाई एक तो फंडोस्कोपी से हम रेटिनल वेस्कुलाइटिस को रूल आउट कर लेंगे। एक अगर कोई इन्फेक्टिव एंडोकार्डाइटिस का पेशेंट है और उसका अंदर हमको रोज स्पॉट देखने हैं, तो वो हम देख सकते हैं। इन सब के बाद भी अगर डायग्नोसिस नहीं बन रहा, देन वी विल गो टू our investigation of choice in piles of unknown origin patient, that is your FDG PET CT scan. Now अभी FDG PET CT scan क्या है? अब हम क्या करेंगे, अब बॉडी में अगर मान लो कोई सेल है, या तो मैलिग्नेंट है या वो सेल में कोई इन्फेक्शन है। अगर इन्फेक्शन है तो वहां पे ल्यूकोसाइट एक्टिविटी, ल्यूकोसाइट्स होंगे वहां पे। अब ये सेल्स क्या होती है, जो मैलिग्नेंट सेल्स जो होती है और जो एक्टिविटी ल्यूकोसाइट सेल ये होती है, ये क्या करती है, अब इनको भूख लगती है, एनर्जी चाहिए, इसलिए इनको ग्लाइकोलाइसिस करनी है। तो जब हम पेट सीटी करते हैं, ये पैथोलॉजिकल सेल्स क्योंकि इनकी ग्लाइकोलाइसिस की पावर ज्यादा होती है, तो ये इस एफडीजी पेट सीटी स्कैन को ले लेगी। तो दी सेल ऑन सिंटोग्राफी विल अपीयर एज एन abnormal cell. अब अगर हमें कोई, हमने पेशेंट का, पाइलोस अननोन ओरिजिन का पेशेंट था, हमसे डायग्नोसिस नहीं बन रहा था, तो हमने फिर उसका एफडीजी पेट सीटी स्कैन कराया। एफडीजी पेट सीटी स्कैन कराने के बाद हमें अगर लगा कि सिम्टोग्राफी इसकी अब नॉर्मल है, तो हम उस एरिया की बायोप्सी और कल्चर करेंगे। अगर हमें पेट सीटी स्कैन पे वो एरिया मिल गया जहां हमें लग रहा है एबनॉर्मेलिटी है या कोई पैथोलॉजिकल कंडीशन है, हम उसकी क्या करेंगे, बायोप्सी और कल्चर करेंगे और फिर डायग्नोसिस की तरफ बढ़ेंगे। बट मान लो फिर भी हम पिछले डायग्नोसिस नहीं बना पाते, फिर भी हम पिछले डायग्नोसिस नहीं बना पाते, तब क्या करेंगे, तब हम उसकी हिस्ट्री को रिपीट करेंगे, उसका फिजिकल एग्जामिनेशन भी हम रिपीट करेंगे, और जितनी भी पीडीसीज है, जो हमारे क्लूज है, उनको दोबारा देखेंगे और दोबारा डायग्नोसिस की तरफ हम बढ़ेंगे। तो कुल मिला के हमारे पास एक पायरेग्जिस अननोन ओरिजिन का पेशेंट आया, हमने देखा क्या ये पेशेंट पायरेग्जिस अननोन ओरिजिन की डेफिनेशन को जस्टिफाई कर रहा है, हाँ कर रहा है। हमने सारी इन्वेस्टिगेशन कराई, फिर भी कुछ भी नहीं निकला। उसके बाद हमने फ्रॉडुलेंट फीवर और प्रैक्टिस फीवर को रूल आउट करा। उसके बाद हमने ड्रग इंड्यूस फीवर को रूल आउट किया। उसके बाद हमने देखा क्या कोई पीडीसी है, क्या कोई क्लू है। अगर क्लू है तो हम उस क्लू की तरफ बढ़े। ये क्लू मिसलीडिंग भी हो सकता है, लीडिंग भी हो सकता है, बट कभी भी क्लू हमें इसकी तरफ लीड तो करना ही करना है। मिसलीडिंग हुआ तो कोई बात, अगर एक क्लू मिसलीडिंग है और या एक क्लू एब्सेंट है, तब हम फंडोस्कोपी करेंगे। फंडोस्कोपी क्यों, रेटाइनल वेस्कुलाइटिस के लिए या फिर रोज स्पॉट्स के लिए। अब हमने ये फंडोस्कोपी कर ली, इसमें भी कुछ नहीं आया, देन हम क्या करेंगे, हम एफडीजी पेट सीटी स्कैन करेंगे। एफडीजीटी पेट सीटी स्कैन क्या बताएगा, ये बताएगा कोई अबनॉर्मल सेल और कोई मैलिग्नेंट सेल्स के बारे में, क्योंकि जो मैलिग्नेंट सेल होगी या कोई एक्टिवेटेड ल्यूकोसाइट सेल्स होगी, वो ग्लाइकोलाइटिक सेल्स होती है, उनको भूख लगती है, एनर्जी चाहिए होती है, ग्लाइकोलाइसिस चाहिए होता है, इसलिए वो पेट सीटी स्कैन को ले लेगी। अगर हमें कोई ऐसी अब नॉर्मल सेल मिल जाती है सिम्टोग्राफी पे, तो फिर हम उसका बायोप्सी कल्चर करेंगे, फर्दर इन्वेस्टिगेट करेंगे। अगर नहीं मिलती, तो हम दोबारे हिस्ट्री को रिविजिट करेंगे और दोबारे फिजिकल एग्जामिनेशन दोबारा से करेंगे कि हमने कोई चीज मिस तो नहीं कर दी। आई होप आप सबको आप समझ में आ गया कि पैरालिसिस ऑफ अननोन रीजन को डायग्नोसिस हमें कैसे करना है। एंड हैज एवरीवन अंडरस्टूड दिस इंपॉर्टेंट फ्लो चार्ट? इफ नो, देन यू कैन मैसेज मी आल्सो, जस्ट गिव मी thumbs up if you have understood this chart. Then we will proceed further. Has everyone understood? No. What are these TDC? TDC are localizing signs, symptoms, and abnormalities potentially pointing towards a diagnosis. ओके, पीडीसी के बाद हम पेशेंट की हिस्ट्री देखेंगे। हिस्ट्री में क्या देखेंगे, फीवर पैटर्न देखेंगे, ड्यूरेशन देखेंगे, कोई ड्रग इंड्यूस फीवर तो नहीं है वो देखेंगे, पेशेंट की फैमिली हिस्ट्री लेंगे, कोई एनिमल कॉन्टेक्ट की हिस्ट्री पूछेंगे। ओके, आफ्टर दिस क्या करेंगे, फिजिकल एग्जामिनेशन करेंगे। फिजिकल एग्जामिनेशन क्या एग्जामिनेशन करेंगे हम, आई देखेंगे उसकी, कोई लिम्फेडेनोपैथी तो नहीं है वो देखेंगे, हिपैटोस्प्लियोमेगैली तो नहीं है, लिवर स्प्लीन पाल्पेबल तो नहीं है वो देखेंगे, स्किन देखेंगे। व्हाट विल सी, वी विल सी स्किन ऑफ द पेशेंट। देन कम्स योर इन्वेस्टिगेशंस। क्या इन्वेस्टिगेशन कराएंगे, सबसे पहले हम वी विल स्टॉप एंटीबायोटिक एंड ग्लूकोकॉर्टिकॉइड ट्रीटमेंट। क्यों, क्योंकि एंटीबायोटिक जो है, इट कैन ऑल्टर ब्लड कल्चर एंड यूरिन कल्चर, एंड ग्लूकोकॉर्टिक कैन डिक्रीज साइज ऑफ lymphadenopathy। उसके बाद हम देखेंगे कि पेशेंट को मिलियरी टीबी तो नहीं है, और मिलियरी टीबी के लिए बेस्ट चीज क्या है देखने के लिए? वी विल डू अ लीवर बायोप्सी। हम एक ट्यूबरक्लिन स्किन टेस्ट करेंगे। Why we'll do tubercular skin test? Because in countries like India, here TB is very much common. So we'll do a tubercular skin test. For miliary TB, we'll do a liver biopsy. After that, we will do a fundoscopy. Then comes our most important, that is our investigation choice. Can can anybody tell me in comment section what is the investigation choice for pyrexia of unknown origin patient? Anyone in comment section can tell me what is the investigation choice in pyrexia of unknown origin patient? Anyone? What is the investigation choice in patient of Pyrogens of unknown origin? That is your fluorodeoxy glucose PET CT. ओके, मैकेनिज्म ऑफ एक्शन क्या है इसका, कैसे एक्ट करता है? दिस एफडीजी accumulates in tissue with high, कहाँ accumulate होता है ये? जहाँ ग्लाइकोसिस ज्यादा होती है, विद हाई ग्लाइकोसिस रेट, दैट इज योर malignant cell और एक्टिवेटेड ल्यूकोसाइट्स। ठीक है, फिजियोलॉजिकल अपटेक, कुछ there are some organs in our body which can physiologically take your FDG precipitation. Which are these organs which can take physiological uptake? These are your brain, heart, your bowel, your bladder, your kidney. Okay, now we will come to our PET CT scan. Now see this FDG PET CT scan. So I'm zooming it out now. This is your normal FDG PET scan. This is your normal. See your brain, your tonsil, your lingual tonsil area, your kidney, your bladder has normally uptake that PET CT scan. So this is the normal FDG PET CT scan which is taken by some tissue, because we have studied that there are some tissues in our body which can physiologically uptake this PET CT scan. That is your brain, heart, bowel, bladder, and kidney. After this come your this pathology part. See in this patient, you are seeing this vessel, this large vessels have taken up this PET CT scan, because this is a patient who is suffering from large vessel vasculitis. And these cells which have taken, these are your activated leukocytes. These are your activated leukocytes which has taken this PET CT scan. So this is the patient of large vessel vasculitis. So you can see that this is a normal PET CT, this is a normal, and this is a large vessel vasculitis patient PET CT. And here you are seeing that this large vessel has taken up this PET CT scan. Okay. So if no diagnosis on FDG PET CT scan is made, what we will do? we will do further investigation, and we will revisit history. We will do lymph node biopsy. We will do CT scan. So कुछ तो गड़बड़ है दया, क्या दया, कुछ तो गड़बड़ है। पेशेंट जब हमारे पास फीवर ऑफ अननोन ओरिजिन का आएगा, हमें हमेशा सस्पेक्ट करना है कि कुछ तो गड़बड़ है। सो अगर एज पर हैरिसन, एफडीजी पेट सीटी स्कैन वाज इन्वेस्टिगेशन श्योर, एंड आफ्टर एफडीजी पेट सीटी स्कैन स्टिल यू आर नॉट एबल टू फाइंड आउट द कॉज, स्टिल यू आर इन डाउट कि भाई पेशेंट का डायग्नोसिस नहीं बन रहा, तो हमें क्या सोचना है? नहीं, हमको यही सोचना है कि भाई पेशेंट का डायग्नोसिस नहीं बन सकता। हमें फिर दोबारा सोचना है कि हमारा लूप होल क्या है। जैसा आपने सुना है ना, दया कुछ तो गड़बड़ है, हमें वो गड़बड़ फिर ढूंढनी है। और कैसे ढूंढेंगे वो गड़बड़? वी विल फर्दर इन्वेस्टिगेट एज पर हैरिसन जनरल टेक्स्ट बुक कि अगर एफडीजी पेट सीटी स्कैन नॉर्मल आ रहा है, इसमें भी कुछ नहीं आ रहा, देन वी विल मूव ऑन टू सीटी चेस्ट, सीटी एब्डोमिन। और सीटी चेस्ट, सीटी एब्डोमिन भी अगर नॉर्मल आ रहा है, देन वी विल मूव ऑन टू, अगेन वी विल रिविजिट आवर हिस्ट्री, बिकॉज वी हैव टू फाउंड दैट मिस्टेक विच वी आर डूइंग। सो दया कुछ तो गड़बड़ है, तो हमें पायरोजेनिक का डायग्नोसिस ढूंढना है। और जब हम बार बार हिस्ट्री को रिविजिट करेंगे, when we will do other investigations and we will revisit history, we will be able to find out the diagnosis of our Pyrogen of unknown origin, and we will label it as a diagnosis. So ये गड़बड़ है बाबा, हमने गड़बड़ को निकाल लिया, ये गड़बड़ है बाबा। So everyone is getting my point. You have to again do further investigation. You have to reinvestigate that patient. फिर से प्रॉपर हिस्ट्री लेनी है, आपको वो गड़बड़ पकड़नी है। Everyone is okay with me? Then give me thumbs up. So I will tell you a patient. So this was a patient of abdominal pain, and we were investigating. हम उसको इन्वेस्टिगेट बार बार कर रहे थे, कुछ नहीं आ रहा। हमने उसको पेशेंट का एफडीजी पेट सीटी स्कैन कराया, वो भी नॉर्मल था। उसके बाद हमने उसका करवाया सीटी चेस्ट एंड सीटी एब्डोमिन। इन सीटी एब्डोमिन व्हाट वी फाउंड दैट देयर वाज सम थिकनिंग इन ileal loops. So when we found that there was some thickening of ileal loop, we sent this patient to a gastro department. वहां पे उसकी colonoscopy, and in colonoscopy what we found that that patient was having a Crohn's disease. So this was a patient of Crohn's disease. And why we were able to find out that we were always are thinking what कि कुछ तो गड़बड़ है। अगर पेट सीटी भी नॉर्मल है, फिर भी हमको सोचना है कुछ तो गड़बड़ है। एंड लेटर ऑन वी वर एबल टू फाइंड आउट द डायग्नोसिस दैट ये गड़बड़ है बाबा, इसको तो Crohn's डिजीज निकला रे बाबा, समझे? Now we will tell you that there was one patient, he was having na anemia and fever for a long time. He was having fever and anemia. So then we sent a thorough investigation, and we also had a protein electrophoresis also. And that protein electrophoresis would come out to be negative. Now we were confused, and patient was anemia was day by day getting more severe and severe, and patient was then was also having a hemolytic kind of anemia. Then what we do, we send serum immunolactophoresis. Because you all know that in multiple myeloma, one is protein electrophoresis and other is immunolactophoresis. And protein is 60 to 80% sensitive, but immunolactophoresis is very much sensitive. And when we send immunolactophoresis, that come out to be positive. So this was multiple myeloma patient which was presenting to us with fever. तो ऐसे सोचना हमें हमें गड़बड़ ढूंढनी है। Now I will tell you another patient. This was a patient of us. He was having a he was having history of proper fever, vomiting. She was an old lady. उसको रोमेटो अर्थराइटिस था, हमारे पास कहीं से रेफर होके आई थी वो पेशेंट। एंड वी वर डूइंग थोड़ा इन्वेस्टिगेशन, फीवर कुछ भी नहीं मिल रहा, कुछ नहीं मिला हमें। देन वी डू सीटी। इन सीटी व्हाट वी फाउंड दैट देयर वाज अ लोअर लोब कैविटी। क्या थी? उसको लोअर लोब कैविटी। अब पेशेंट को रोमेटो अर्थराइटिस भी था, तो हमें लगा कि लोअर लोब कैविटी कभी रोमेटो अर्थराइटिस की वजह से तो नहीं होगी, कभी हो जाती है। एंड देन वी वर कंटिन्यू थिंकिंग, एंड हमने उसका प्रोकैल्सिटोनिन लेवल भेजा। एंड वी ऑल नो दैट प्रोकैल्सिटोनिन लेवल जो होता है वो बैक्टीरियल में बड़ा होता है, एंड उसका प्रोकैल बड़ा हुआ आ गया। एंड देन वी वर थिंकिंग यार टीबी तो जो कैविटी करता है अपर लोब में करता है, लोअर लोब में तो नहीं करता। एंड वी वर थिंकिंग कि पेशेंट क्योंकि रोमेटो अर्थराइटिस का था, तो उसकी लोअर लोब की कैविटी शायद उसको रोमेटो अर्थराइटिस की वजह से होगी, बट उसको प्रोकैल पॉजिटिव आया था। देन वो उस पेशेंट को हमने फिर पल्मोनोलॉजी में आगे फर्दर रेफर किया। देन उसकी वहां से बायोप्सी हुआ, उसका सैंपल वैंपल लिया गया वहां से, एंड लेटर इट टर्न्स आउट टू बी टीबी। सो दिस वाज अ कॉमन डिजीज टीबी which was having a rare presentation as a lower lobe cavity. So that's why you have to have a broad view when you are taking patient. You have to revisit history. And the most important thing that I have told to you that Pyrexia of unknown origin is due to a atypical presentation of a common disease rather than a rare disease. Okay, so if PET CT is normal, then what we will do? We can either do a lymph node biopsy or we can do a CT chest and abdo. I will tell you one more case ना. ये एक पेशेंट हमारे पास आया, उसको फीवर था एंड WBC रेज वगैरह थे, एंड अगेन इसको 1.5 हफ्ते से 1.2 वीक से फीवर था एंड कोई सिम्टम नहीं है, कुछ नहीं है. पेशेंट वाज टेलिंग कि ओकेजनली एब्डो पेन होता है, सब कुछ होता है, कोई डायग्नोसिस नहीं बन पा रहा, कोई कफ नहीं है, स्पूटम नहीं है, सब कुछ कुछ समझ नहीं आ रहा, CRP ये सारे कुछ खास रेज नहीं थे. तो वी वर इन कंफ्यूजन कि भाई क्या है इस पेशेंट में. देन USG करवाया हमने एंड व्हाट वी सी दैट देयर वाज स्मॉल liver abscess in this patient. There was a small liver abscess. And when you will read a liver abscess, especially in Harrison, you will find that many of them that liver abscess present as a pyrogen of unknown origin. So that's why you have to take history, because in history he was telling us abdominal pain that was mild abdominal pain. So I was like, yeah, हाँ चल mild abdominal pain हो रहा है, एक बार इसका USG करा के देखो. So you have to think. And this in this patient, this mild abdo pain was like a PDC. This was a diagnostic clue. And when we get this diagnostic clue, we have to evaluate in terms of the diagnostic clue. So this patient was having abdominal pain as diagnostic clue. So evaluate further this diagnostic clue, and later turn out to be a liver abscess. So you must have a broader view whenever you are seeing the patient in your ward on casualty. So if PET-CT is normal, do a lymph node biopsy or do a CT chest and abdo. Also, you can do a temporal artery biopsy on any patient which are greater than 55 years of age. You can also do liver biopsy if you are suspecting miliary TB or any liver. If still not diagnosis made, then revisit history and examination. Now, I will tell you one or two more factors. First is your ASR. Suppose there is a patient who Pyrogens unknown origin patient, but his ASR is increased like more than 100. So you can think about some causes. There are some causes of extremely elevated ASR which are greater than 100. What are the causes? These are endocarditis, your abscess, your UTI. These are your giant cell arteritis, SLE, multiple myeloma, leukemia, lymphoma, and one is TB also. So if you are getting ASR above 100, so there are few causes of ASR above 100. So suppose there is a patient with unknown origin, his ASR was there, suppose above 100, but you are not able to find any cause. Then you can go and see about what are the causes which have ASR greater than 100, and these are the sub causes of ASR greater than 100. Then you can go and investigate in these causes. This how you should proceed your diagnosis, because any clue you are getting, you should investigate on that clue. Other is that your CRP. But problem with CRP is that CRP is increased in both infectious and non-infectious. But your procal, your procal is only increased in bacterial infection, or most of the time it is increased in bacterial infection only. Okay. Now there is one interesting thing, that is your naproxen test. Naproxen is an NSAID you know, and naproxen test in Pyrogens of unknown origin patient. So what we have seen that when to any patient we give a 375 mg naproxen, that is per oral BD. That is one day you have to give twice. If fever resolved or not. If it is yes, if it is yes, then it is infectious. And if not, then likely it is in an infection. And this test has around 67% sensitivity. So there is a test known as naproxen test, was used earlier now. In this, we have to give 375 mg of naproxen tablet per oral BD. If what the people have seen when they are doing this trial, that अगर fever resolved हो रहा है, अगर fever resolved हो रहा है, तो it is likely a malignancy. Sorry, it is likely a malignancy. अगर fever resolved हो रहा है, it is likely a malignancy. But अगर fever resolved नहीं हो रहा, तो then it is a likely a infection. So this is your naproxen test. Now comes last your treatment part. So in treatment part, first is your question, because I've seen that you have to stop all antibiotic and all your glucocorticoid. So first is your empirical trials. Now in which patient you have to give empirical trials or empirical treatment? In patient who are deteriorating, in patient who are deteriorating, or who are unstable, or they are having any neutropenic fever, neutropenia fever is there. So in these patients you have to give your empirical treatment. And suppose you are giving empirical treatment, especially of ATT, because most common infection doing pyrogen origin is your TB. So if you are giving ATT, and if patient is not responding within 6 weeks, then you have to think of alternate diagnosis. So if your patient is a pyrogen of unknown origin and you are giving ATT, so give it for till 6 weeks. If in 6 weeks patient respond, then it is very good. You must continue with your treatment. If don't, then think of any alternate diagnosis. Other treatment option is your colchicine, which is given specially in your familial Mediterranean fever. Other are your glucocorticoid. Glucocorticoid beautifully, especially disease like giant cell arthritis or polymyalgia rheumatica. Now, these is a beautiful response to glucocorticoid. But in infections and malignant lymphoma, if you give glucocorticoid, what glucocorticoid will do? It will suppress your fever, and then there will be infection, but without fever. And what you will think, यार fever तो आने रहा, मतलब शायद infection भी नहीं होगा. So if you are giving glucocorticoid infection malignant lymphoma, it will mask the symptoms. It will mask the symptoms. Other treatment is your your interleukin 1 inhibitors, that is your Ankindra, and they are used in especially familial Mediterranean fever, scale disease. Okay, then last is your prognosis. Now, what we've seen that mortality due to fever of unknown origin is decreasing because now you are able to do proper investigation. Now new treatment modalities are coming. That's why this modality prognosis now is very good day by day. So now here we are completing and ending a section of fever. I hope you have understood all the things. We have covered fever from pathogenesis, from mechanism. We have covered fever with rash. We have covered fever with of unknown origin in great detail. Now you will able to diagnose. I am again repeating. First, whenever any patient who's labeled fever with unknown region, check the definition. Is that patient is fulfilling the definition or not? That is more important because you generally found that there are some quack doctors who are like, हाँ एक हफ्ते से डायग्नोसिस होना है शायद सर ये फीवर अननोन ओरिजिन होगा. ऐसे नहीं. हमें देखना है कि यार ये जो पेशेंट है ये प्रॉपर डेफिनेशन में फिट हो रहा है या नहीं हो रहा. सो ऐसे कुछ नहीं किया. अगर एक दो हफ्ते से आप डायग्नोज नहीं कर पा रहे, आप उसको लेबल कर दो पायरेक्स अननोन ओरिजिन. नहीं. पेशेंट मेरे पास आया, पेशेंट को बुखार था 3 हफ्तों से ज्यादा. मैंने सारी ऑब्लिगेटरी इन्वेस्टिगेशन करवाई, एएसटी, एएलटी, प्रोटीन लैक्टोफोरेसिस सब करवाया. उसके बाद मैं लेबल करूंगा कि हाँ ये पेशेंट पायरेक्स अननोन ओरिजिन है. उसको लेबल करने के बाद मैं जो भी ड्रग है वो सब स्टॉप करूंगा कि ड्रग इंड्यूस्ड फीवर तो नहीं है कभी इसको. उसके बाद मैं पेशेंट की हिस्ट्री को रिविजिट करूंगा. क्या कोई क्लू है, कोई टीडीसी है, कोई मुझे क्लू मिल रहा है जिसको मैं आगे जा सकता हूँ. हाँ, अगर मेरे को क्लू मिल रहा है तो मैं उस क्लू के आगे तरफ बढ़ूंगा. अगर मुझे लगता है उस क्लू को मैं बायोप्सी कराना चाहिए, उसका टेस्ट होना चाहिए, मैं उसका टेस्ट करूंगा. अगर क्लू नहीं मिल रहा और क्लू से भी कोई डायग्नोसिस नहीं बन पा रहा, देन व्हाट आई विल डू अ एफडीजी पेट सीटी स्कैन. आफ्टर डूइंग एफडीजी पेट सीटी स्कैन मेरे को कुछ एबनॉर्मलिटी मिली ही नहीं मिली. अगर पेट सीटी स्कैन में मुझे कोई एबनॉर्मलिटी मिल गई तो देन मैं उस टिश्यू का फर्दर इन्वेस्टिगेशन करूंगा, बायोप्सी कराऊंगा, जो भी करूंगा. बट अगर स्टिल ऑन एफडीजी पेट सीटी पे भी मेरे को कुछ नहीं मिल रहा, देन व्हाट हैरिसन इज सेइंग दैट you will do a chest and abdominal CT. Why we are doing chest and abdominal CT after PET CT? Because in chest and abdominal CT there are more radiation, na? So there are more chances of harm. That's why we are doing FDG PET CT. But problem is that in India many centers are not having FDG PET CT scan. So in India, country like us, we should directly move on to CT chest and CT abdomen. We are not having any facilities of PET CT scan. तो अब हम क्या करेंगे, हम सीटी चेस्ट और सीटी एब्डो करेंगे. अगर सीटी चेस्ट सीटी एब्डो करने के बाद और अगर पेशेंट की 55 से ज्यादा है, टेम्पोरल आर्टरी बायोप्सी करने के बाद भी अगर हमने डायग्नोसिस नहीं बन पाया तो हम हिस्ट्री को रिविजिट करेंगे. क्या करेंगे? हिस्ट्री को रिविजिट करेंगे. क्यों? क्योंकि कुछ तो गड़बड़ है दया. हमें वो जो कॉज है वो ढूंढना है. हमें वो कॉज ढूंढना है. और जैसे मैंने आपको बताया कि मैनी टाइम्स जो पायरेक्स अननोन रीजन टू एटिपिकल प्रेजेंट ऑफ रेयर डिजीज. Because if TB is presenting as extra pulmonary tuberculosis, then it is very difficult to diagnose it. And also, you have to do proper examination. I know there is one patient who was a lymphadenopathy patient, and our resident was like, "Sir, कोई lymphadenopathy नहीं है." And that patient was having a small cervical lymph node in this area. So after conclusion taking history, then after 2 or 3, we again do a proper examination, and we found that there was cervical lymph nodopathy. And after that, when we sent its biopsy, it turns out to be a tuberculosis. So आपको हिस्ट्री फिर से रिविजिट करनी है कि कुछ गड़बड़ तो नहीं है. और जैसी गड़बड़ मिल जाए और डायग्नोसिस हैज बीन मेड, बिकॉज यू आर एबल टू फाइंड ये गड़बड़ है बाबा, और गड़बड़ मिल गई, डायग्नोसिस आपका बन गया. सो यू हैव टू फाउंड दैट डायग्नोसिस. So proper history, proper examination, and doing your investigation again and again. That's how. Because sometimes what happen ना कि पेशेंट को मान लो कोई लीजन है, कोई दिक्कत वो फर्स्ट वीक पे दिख रही है बट थर्ड वीक पे नहीं दिख रही. और ऐसा भी हो सकता है कि मान लो पेशेंट आपके पास आया और उसको मान लो कोई लंग लंग में कुछ डैमेज, कुछ इंजरी हुई है, बट फर्स्ट वीक में एक्सरे में नहीं आया. बट आप जब आपने थर्ड वीक के बाद दोबारा एक्सरे कराया, वट यू वर एबल टू सी दैट हाँ एक्सरे में कोई पैची ऑपेसिटी दिखी है आपको लेफ्ट या अपर लोब में, एंड देन यू वर एबल टू गो विद इट, एंड देन यू वाज एबल टू फाइंड डायग्नोसिस. तो ऐसा हो सकता है. दैट्स व्हाई यू हैव टू revisit history and again reinvestigate that patient to find that key. Okay, with this, we are ending our session today, our session. Thank you. Like and share this lecture. Goodbye.